and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right. Very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Khanduja, consultant orthopedic surgeon in Cambridge, UK, and also one of the founders of SICOT Pioneer and the president to SICOT currently as well. And it's indeed a pleasure to welcome all of you logging in to this webinar from all around the world. Now, SICOT Pioneer was born during COVID as a small platform and has grown enormously over the last few years. We've certainly embraced the digital future for SICOT, and through this platform, we've done over 90 events and have had over 120,000 views from 110 countries around the world. So big thank you for joining us and following us as well. Now, today's webinar, as you are well aware, is focused on the management of calcaneal fractures. And I'm immensely grateful to Dr. Arvind Puri, who's the chair of a Foot and Ankle Committee, and also the Indian Foot and Ankle Society to do this combined webinar with SICOT. I'm also very grateful to the stellar faculty who've given up their precious time for this webinar, and I will let Arvind introduce them to you in a second. We'll try and make this webinar as interactive as possible, so please do post in your questions. And if you can't join us today, then you can access the webinar on the on-demand SICOT platform. Once again, a big thank you for joining us. And we do hope that you do enjoy this webinar. Over to you, Arvind and Rahul. Thank you.
Thank you very much, Vikas, for the introduction. And first of all, I'd like to welcome everyone who has joined this webinar, which is on calcaneal fractures, and the theme is that less is more. I would also like to thank SICOT and IFAS for the collaboration on this particular event. So to get this webinar off the mark, I'm honored to introduce the prestigious faculty. Starting first is Labidi, who's a foot and ankle specialist and consultant orthopedics at the University Hospital of Birmingham. She specializes in MIE as well as foot and ankle trauma and is an educational lead in the training of orthopedic trainees and young surgeons. She's also enviously a polyglot. She's fluent in 5 different languages, and her topic is going to be on classification, assessment, and the sinus tarsi approach. Next, following Labidi, is Moez Ballal, and he is from Abu Dhabi. He is a surgeon, foot and ankle specialist at the Sheikh Sheikhout Medical City, and his interest is foot and ankle trauma as well as reconstruction, and he is a member of the British Orthopaedic Foot and Ankle Society as well as SICOT. His topic is going to be on percutaneous and arthroscopically-assisted fixation. Following Mo is none other than Professor Stefan Rammelt, who needs no introduction. He is the head of the Foot and Ankle Division at the Center for Orthopedic Trauma and Plastic Surgery at Dresden in Germany, as well as the president of the Foot and Ankle Society of Germany. He's also the editor-in-chief of the Journal of Foot and Ankle Surgery and has presented and published extensively. He's going to talk about gems from the master, and I think it will be a treat to listen to his talk. Last but not the least is Rahul Upadhyay, and he comes from the Rajasthan hospitals in the city of Jaipur in India. He is a very experienced foot and ankle surgeon and has been the secretary of the Indian Foot and Ankle Society with a large interest in foot and ankle trauma as well as correction of deformity. And his talk is going to be on experiences of the experienced. So not to waste any more time, I'd be very grateful if we could start off with May Labidi presenting her talk. Thank you.
Thank you very much, Arvind. Good afternoon in my case. Good evening, good night, and good morning to everybody. So as introduced, so my topic is about the assessment, the classification, and the sinus tarsi approach, which my colleagues will further discuss in their presentations. So I'd just like to highlight the importance of the anatomy of the calcaneum being one of the main big bones in the hind foot, and having that structure, that three-dimensional structure with multiple joint surfaces. I always have with me a bone model, sort of to get my head around when I have any cases and when I discuss with patients. To start with classifications, so the classification is mainly divided into intra-articular, extra-articular. So the extra-articular is less the topic today. However, I'll just go quickly through it. It accounts for 25% of fractures of the calcaneus, and it's mainly avulsion fractures and fracture of the system-tacculum talus. As for the intra-articular, that account for 75%. Mainly we use standards, I believe, across the world. However, there is the Essex-Lopresti classification that is quite historical. It was formed in 1952. Fun fact. And it is mainly based on a lateral X-ray view. So as you see, so there is one primary line of the fracture, which depends where the fracture is going to proceed, and that goes through the posterior facet. So it's either heading towards the back or more of an axial. And based on that, it will depend where does the secondary fracture line go, which is more, would it go more vertical or more horizontal in the case of the tongue shape. There's also a possibility of viewing those and assessing those for the tongue type 1 on an axial view, as you see at the bottom. Going forwards, as mentioned, the Sanders classification that is based on a CT scan, and that's the gold standard nowadays in most of the world. It's based on how many fracture lines and how much is it displaced. In short, 4 types. Type 1 is no matter how many fracture lines go through the posterior facet, it shouldn't be displaced. That defines the type 1. As for the type 4, it defines it by being multi-fragmentary and displaced. In between, which is type 2. So type 2, there are 3 lines, 3 different lines, 3 different types, type A, B, and C. It all depends on where the line, the intra-articular line, is closer to, whether it's the lateral, middle, or medial. And in the type 3, it's a combination of the type 2. In terms of the assessment, which is quite important, unfortunately, these days probably we rely mainly on images and not on examination, physical examination, history taking. History taking is very important. The mechanism of injury clearly is highly important, whether it's a high energy injury or whether it's a low energy, what to expect, soft tissue, and so on and so forth. Especially speaking about the sinus tarsi approach, which is it's quite important for the soft tissue. Physical examination: are there bruises? Are there blisters? What's the skin condition? Is there's a deformity, which is the most typical? Is there shortening or widening of the heel? In terms of palpation, is there tenderness or not? Stress test for the stress fractures mainly. Otherwise, with the heel fractures, it's normally quite straightforward. Whether there is any discontinuity in the Achilles tendon in terms of an avulsion fracture, or whether there is a danger from a compartment syndrome, and clearly the wrinkle sign, which is a generic really sign. And quite important, especially in today's topic that we're discussing with minimally invasive approach, is the neurological and the vascular status. So that's the main difference between the lateral external style approach and the sinus tarsi approach, that in those cases we can really be quite mindful of both of these. Going forwards to the imaging, which in most places we probably head straight towards the imaging, unfortunately. Standard imaging, radiographs, that's just a standard that we start with. As I mentioned, so the Essex Lopresti classification is based on the lateral views, plain radiographs. In terms of intraoperative, so a quite important and very useful one is the Broaden view. It is quite important for us surgeons to know how to position the patient, not to rely too much on radiographers and technicians, as we really need to know that, and that is extremely useful because we can have an idea of the posterior facet. Harris view, again, it's an axial view, quite simple to perform. We really need it intraoperatively, and it's just about positioning the foot properly and having enough space, and making sure that the radiographer has their C-arm on brakes. AP of the ankle, it helps us in case there is any potential lateral burst of lateral extrusion of the wall and an impingement. What are we assessing on the X-rays? One of the quite popular measurements are the angles, Gowreeson angle and Ballal angle. So they basically tell us about the collapsing of the posterior facet. So whichever you're doing, even though it can be quite obvious, but it's probably useful to do those. As mentioned earlier, so the CT is probably the gold standard everywhere. I'm more of a sort of an old-fashioned person, so I prefer to go through all my planes on my own rather than having a three-dimensional reconstruction, which some people find quite useful. And I think it's quite important to really go through every plane and to properly sort of plan what are you going to do and where are your fragments and so on and so forth. MRI in case of stress fractures, if we're not certain whether there is a fracture or not. That's something that is probably the only radiological assessment that we can do that other ones can't help us with. In terms of the approach, finally, with the sinus tarsi approach that my colleagues, as mentioned, will speak of into more detail. The main idea of this minimal invasive surgery is to save the soft tissue, to save nerve injury, nerve irritation, to reduce the infection and the blood supply clearly, and also to reduce surgical time. In terms of visualization, so what do we see with this? So it is quite unusual to say, hey, let's do this small incision and not that lateral extensile, and we're going to see the same thing. Well, the learning curve is probably quite long. However, it is possible. What we see the posterior facet, anterolateral fragment, and lateral wall. It can also be utilized for subtalar fusion. I've done one a couple of days ago, as a matter of fact. This is an illustration of how it looks and what you need to do. So one of the important things is the positioning. Basically, if you don't have a proper position of the patient, you're not happy with the position, you're not going anywhere. You're going to struggle from the beginning. I prefer lazy lateral, but it's really a personal preference, so it doesn't matter as long as you're happy with the position. As long as you bear in mind what's the hip like, is there any possibility of dislocation? Is it stiff or whatnot? To be able to move around with your foot and do your views that we mentioned earlier. So this is the tip of the fibula. This is the base of the fourth metatarsal. Just draw a line in between, and you would be aiming in the posterior bit. If you need, just extend anteriorly. If not, just use whatever you have. Extensor digitorum brevis is reflected on the top of the foot and the peroneal tendons of the bottom. A helpful tool, a useful tool, is the shunt spin if you need to do any traction. That's something that my colleagues will discuss. And finally, just as a quite useful maneuver, which is the Essex Lopresti, it's really just a basic sort of logical, reduction of the fragment fracture, but it's quite useful to have that in mind. In terms of conclusions, because my presentation is mainly things that we do know and we should know, I'd just like to highlight that we really need to know that our anatomy, and as I said, I always have this model with me, so it's quite useful also for patients to better understand and for residents. In terms of the approach, it's maximize your view and do. So the small hole, get the maximum and minimize your incision. And please do plan properly and prepare thoroughly. That's essential and that's crucial. Thank you very much. And this is my contact if anybody would like to contact me further. Thank you.
Thank you very much, May. Mo, you're up next. So if you don't mind sharing your screen, please, and starting your chat.
Okay, just a second. Can you see it? Can you hear me, everyone? Right, so my topic is percutaneous fixation for arthroscopic and arthroscopic-assisted fixation for calcaneal fractures. So this is where I work. It's a level 1 major trauma center. We see lots of foot and ankle trauma, especially calcaneal fractures. So why are we moving from extended lateral approach? I mean, extended lateral approach for calcaneal fracture has its role. It's got really good outcome in the experienced hands, but we're gradually moving away from that, mainly because we don't want to be seeing this or this, and the management of these can be quite troublesome. So what do we mean by percutaneous fixation? Anything that doesn't involve opening, such as percutaneous screw fixation, percutaneous K-wire fixation, arthroscopic-assisted fixation, and external fixations. So what are the indications? Well, my indications for percutaneous fixation is Sanders 2, 3, and 4. Or when the soft tissues don't allow. Sinus tarsi approach, for example, where you've got open fractures, soft tissue compromise, diabetic patients, blistering, immunodeficiencies. So the best time to perform a percutaneous fixation is within the first 72 hours, ideally within the first 24 hours, where the fracture is still mobile. The fracture hematoma is not sticky, so you can easily reduce these fracture fragments. So why? Again, it gives you a shorter hospital stay, reduces the risk of blister formation from the pressure of the hematoma. You get less wound complications, that's published in the literature, shorter waiting time for surgery, less scarring, and if you're planning a primary fusion, for example, or a secondary fusion within 3 months, then percutaneous fixation is the ideal procedure for you in order to get the calcaneum into a more normal shape in order to make your fusion a less complicated fusion, subtalar fusion. So is there anything, everything is perfect? No, nothing is perfect. So there are issues with MIS or percutaneous fixation. Basically, you don't get a direct view of the fracture. So you're dealing and reducing the fracture indirectly based on an image or a scope image. And there are no standard techniques. There are hundreds of published techniques for percutaneous fixation. And as mentioned before, the different fixation methods. So prerequisites for percutaneous fixation, well, early surgery, again, within the first 72 hours. You need to understand your preoperative images in and out. X-rays, CTs, you need to study them. Take your time and study them carefully. And you need to have the necessary tools to perform the procedure, such as linear distractors, narrow bone punches, small elevators, small joint elevators. Positioning, again, different positioning have been described. You can do them supine, you could do them prone, you could do them lateral. The way I do them is a lateral with the operated side up, with a big firm gel pad under the operated leg, so you can get a proper lateral and you can get an AP as well. You need to center your image intensifier on the talus, and you need to be able to get a lateral view, a broadened view, as I just mentioned, an axial view and a sustentaculum view. So these are your main 4 views that you need to master when you're doing percutaneous fixation. So reduction techniques, I'm going to be talking mainly about 2 types, about the reduction techniques for the tongue-type fracture and the axial depression type of fractures. So for the tongue type, this is what you're aiming for. You're aiming for this screw configuration. Again, this is my technique. Other people will have different techniques. So one longitudinal screw just under the subchondral bone, fully threaded, and another partially threaded from posterior superior to anterior inferior. So an example, you've got a tongue type fracture. These are your standard incisions, one high for your elevator, so you denim pin or threaded pin in order to elevate the posterior fragment. The 2 inferior ones are for your screws. So you insert your pin either through the Achilles or just lateral to the Achilles tendon into the posterior, into the tongue fragment, just under the subchondral bone, plantar flex the foot and elevate the posterior fragment. Then you insert another guide wire, preferably for the 6.5 or 7 millimeter fully threaded screw. So this wire can be used to correct your varus. You really need to lever on that wire in order to correct the hindfoot varus. And then you need to insert the other screw to hold the tongue fragment down. So you can see the screw is already in the subchondral bone. Wire is inserted and it's holding the reduction up, and then that's your partially threaded screw to hold the fragment down. So one screw to hold the fragment, and the other one is to support the subchondral bone. I call it a raft screw. Sometimes this technique is not as easy. For as example, you can see this fragment is way depressed down. I'm trying to lift it up, and you can see the force on the wire, and it's not moving. Sometimes you might need to use other reduction techniques. A small incision on the plantar surface of the foot. You can put a small bone lever or a McDonald in through the fracture line. lift that fragment up. And it just helps you to keep that fragment up, and then you continue with your fixation as described before. Regarding the SX low-prostate depression type, so with the depression type, you have a depression of the articular surface, you have a varus, you have shortening, and you have a lateral aim blowout. With the fixation, I aim for similar fixation, but with a sustentaculum screw again. This is one way of fixing it. There are different published screw configuration. So the steps of the reduction of the depression type, you need to correct the hindfoot varus, then you need to correct the length, then reduction of the central depressed fragment, temporary stabilization with K-wires and screw fixation. Now, you need to invest in something like this. Recently found out the importance of this traction, linear distractor, which are really, really useful for these type of fractures. You'll make your life much easier. You need to get 2 of those. I've got these 2. So you need to insert 2 pins in the foot. One will be in the calcaneal tuberosity, 2.5 millimeter K wires, and one in the talar neck. And I'll show you a diagram in a second. The calcaneal wire should be perpendicular to the long axis of the calcaneum, basically, of the fractured fragment. Okay. Once these pins are inserted, then you need to apply the plantar or the medial traction, linear traction device in order to correct the varus. So that's the position of those wires. Okay. And the calcaneum is usually placed in that position. When you look at it from the end part of the foot, you'll see that those 2 wires are converging medially. You're aiming to get that shortening that you see on the left. With the distractor, you're correcting the length. And then the ways of elevating the central depression, there are different ways. You can use a K-wire joystick, small lateral incision elevated. You can use a plantar incision. And there's a really useful ViewMedi video by Christian Redmond. I highly recommend you that you have to have a look at it. It's a long video, it's about half an hour, but it gives you really good tips and tricks. So what about comminuted fractures, where you have a calcaneal fracture? Basically, it's just a bag of bones. You want to get the length, correct the broadening if possible, correct the height, in order to reform the shape of the calcaneum for the later fusion, subtalar fusion. For example, if you look at this X-ray, or you look at this X-ray, okay. So that's where K-wires come in handy. You're just reshaping the calcaneum into a normalish looking calcaneum for the subtalar fusion procedures. Arthroscopic-assisted fixation, again, the same position, sinus tarsi incisions, put your scope in. And the advantage of the arthroscopic fixation, it gives you that direct visualization of the fracture line. You can use it to remove all of those subtalar debris and loose bodies. You can evacuate the hematoma as well. And through it, you can get a really good direct view of your reduction. With using just an image intensifier, it can give you a really good idea about your reduction technique. But with an arthroscopic view, you're looking at it right there. And as you're elevating the posterior fragment there, you can see it moving nicely there. And then suddenly everything just locks in place. There you go. Okay. Then you'll have those loose fragments that you can nibble and you can remove. So if you have the facilities and the ability, then I would highly recommend that you train yourself on doing these arthroscopic diabetic patient with an active ulcer presented with a tongue type of calcaneal fracture. Then that's where an external fixation becomes really useful. And that's the picture after 3 months being on an X-fix. So in summary, those fixation methods offer really small incision, allow early fixation. It is a continuous and an evolving technique. And so there's a highly need for further comparative studies to compare it with open techniques, and it needs standardization. Thank you, sir, very much.
Thank you very much, Mo, for a very informative and unique talk. I'd like to invite Professor Stefan Rammelt for his talk on gems from the master. Please go ahead, Stefan.
Hello, good afternoon, and thank you very much for the invitation and introduction. Can you see it in the full picture, or do you see the presenter mode?
Presenter mode.
Presenter mode.
Okay. Yeah, one moment. That's better, huh?
Perfect.
Yeah. All right. So I was invited to speak about the sinus tarsi approach, and Labidi has already given a nice background on that. These are my potential conflicts of interest, but you won't find much of the implants from these companies. So the sinus tarsi approach is really a rather safe approach. And for me, as I was growing up with the extensile approaches, it was a game changer, because it takes you 2 or 3 minutes to be at the subtalar joint and have really a nice overview over it. Whereas with an extensile approach, you really have to work your way up, and you have to be very careful. And all the good things that you want to try to save, so the lateral calcaneal artery with all its branches and the sural nerve are all preserved, because you go over the top. The only thing, of course, there's always something you will find is a communicating branch from the sural nerve to the peroneal nerve, to the superficial peroneal nerve, but I doubt that this is of any consequence for the sensation of the patient. Another good thing is, if you stay on that line that Dr. Labidi has shown nicely towards the 4th metatarsal base, then you can extend this approach as needed. So you're not stuck with it in case you're not happy with your overview. You can extend it to the back to see the peroneal tendons and to reattach them if needed, because there's sometimes damage with calcaneal fractures, and you can extend them to the front, to the CC joint, and even over the cuboid. And it has been shown that if you stay on that line, you end up exactly in this, at the center also of the calcaneocubital joint, and you have less wound complications than when you try to bring it down towards the 5th metatarsal base. So we like to call it the lateral utility approach, because on that line, that's relatively surgeon-proof. You can do a lot there. If you start with less invasive approaches, start with the winner, start with the Sanders type 2 fracture, which is displaced. And the first maneuver is always the same as you would do also for the extensile approach. You have to get the tuberosity fragment out of the way. You have to realign the medial wall, because only this makes way for the lateral fragment, no matter how many fragments you have on lateral side, to come back and to be realigned. And then you can twist it and bring it back, no matter if it's a tongue or a joint depression type fracture. And with a very small approach, which is not much more than maybe 2 incisions for the arthroscope and then the 3rd incision for the screw, you are there and you can reliably see the joint. Here you can see the axial alignment, so you avoid shortening and varus. You bring it round. You can use a Shan's pin, as has been noted, but you can also use a distractor, a collinear distractor that is brought in from the side. And then you can first line it up with K-wires, see that you realign the medial wall, and then bring in percutaneous screws. Here you can see the collinear distractor, which helps you bringing the tuberosity out of the way. You might still be tempted to lever it with a smooth elevator, and then really make way for the joint reduction. Here you can see it, and of course you feel free to use a dry scope if in doubt. If the fracture line is far medially, then you might just introduce in a quick manner a dry scope and look inside and maybe clean some debris out and see that you really have a perfect reduction. And then in simple fractures, you can introduce some percutaneous screws, and with very small incisions, you're there. The same is, of course, possible for Sanders type 3 fractures. Again, it's the same approach. It's the same technique. You start with realigning the medial wall, bringing the tuberosity down, and then you can control reduction, and you can, in a shish kebab technique, you can line up all the fragments from the medial to the lateral side. This clamp is also helpful if there's still a little gap in the joint. Then you bring in one branch via step incision over the sustentaculum, and then you can bring those fragments back together. And these are the final radiographs, and these is the follow-up X-ray scan. It shows a perfect reduction of the shape and of the joint. And this is the patient 1 year later. Here's a fracture that you wouldn't dare to touch with an extensile approach, even though the blisters are all on the medial side. You see this is a more severely displaced type 3 fracture, but you can go there from laterally, and you see the blisters are covered from the medial side. You build up your joint from medial to lateral, and you can see with the sinus tarsi approach here on the left side is the interosseous ligament. Here you see those joint fragments nicely realigned and fixed with screws. This looks quite good, but if you have a critical look at the CT scan, you see the joint is nicely aligned, but there's still some broadening of the lateral wall, and maybe the tuberosity shifted up again a bit. So if you have concerns about that, then it's better to slide in a small plate, which can again be introduced in a minimal invasive manner as a MIPO plate. Here we have a patient, a typical patient for calcaneum fracture, construction worker who fell off from a scaffold. You see it's a tongue type fracture, but CT scan reveals additional fragments. So this type 3 fracture at least. Maybe if you count that small fragment here, it's a type 4. And but you can use the same technique. So the joint, the distractor to get the tuberosity fragment out of the way, then a Schenz pin that is introduced into the tuberosity, in the upper part of the tuberosity to bring it down and to move that whole fragment which is carrying the lateral part of the joint. But you have to take care of that intermediate fragments, and they can be aligned from medial to lateral. So sometimes it's useful to bring one K-wire all the way out to the medial side, which is very good if you use a floppy lateral position and you can twist the foot a little bit. And then you just cut it flush with the bone, with the intermediate fragment. Then you bring on the lateral fragment and bring your K-wire or your K-wires back. And if you're happy with your K-wire and you feel that the fragment is relatively small, the intermediate fragment, and you are afraid that the screw will destroy it for good, then you just leave the K-wire in, cut it flush on the lateral side, and leave it as a lost K-wire. In this case here, again, if in doubt, you can use a dry scope for a quick control, particularly for those fractures who go very far medially. And here in this case, it was exchanged with screws, and a small plate was slid in a MIPO technique. So the first screws are always independent screws that aim towards the sustentaculum tali, because that's the strongest part. And then additional screws are just holding the plate in place. I typically like to start with non-locking screws so that the plate is really flush to the bone, so there's no broadening of the lateral wall, and that there is some friction also to the plate, and then you add longitudinal screws as needed. And so this is the function 3 months out, and this is something you simply cannot achieve with an extensile approach. That is when the patients slowly start moving and fight against the scarring. Here you have a very small scar and some stab incisions that have nicely healed. Here another type 3 fracture, severely displaced. So this fragment is really turned 180 degrees upside down. So with the same approach, you can dig in, get it out, get your medial wall realigned. And in this case, we used a slightly longer plate that goes all the way to the tuberosity and holds it and bridges that zone of comminution. Here's the follow-up CT scan. showing the nice joint alignment. If there's some small debris that you're not comfortable with, rather bring it out than to leave it for a later career as a free joint fragment. A gap is very well tolerated. A step is not tolerated, even if it's minimal. And this is the patient 1 year later. If there's displacement also of the calcaneocuboidal joint, you can just extend that approach towards the fourth metatarsal base. And here you can see this is a relatively simple fracture pattern, but there's a step off in both joints. So in the posterior part of the approach, you can control reduction of the subtalar joint. In the anterior part, you can control reduction of the CC joint, and you can control it. Again, you can use the small scope, and then you can fix it, in this case with screws. Get a lateral view, get a broadening view to see the subtalar joint, to see that the screws go into the sustentaculum. And this is the next review, and get an additional dorsoplantar view to see that the CC joint is nicely aligned. And here's another one, more severely displaced. Here you can see how the lateral wall is blown out and how that big lateral fragment is really pushing against the fibula. So this patient also had a dislocation of the peroneal tendons. So the approach was extended to the back and to the front. Here you can see the CC joint nicely reduced, the subtalar joint in the back, and this distractor on. And this is the final result. You see the broadening view, you see the lateral view, and you see how the joints and the shape is restored. Is there some evidence that minimal invasive surgery is really good? There is, but you have to really make sure that you have an adequate anatomic reduction, adequate stability. A lot of those studies just show the bular angle, which is something you see on x-rays and fluoroscopy, don't show broadening views, or CTs don't show the joint reduction. So it's really important in order to get a good result to have a perfect reduction, because the subtalar joint is a very non-forgiving joint. And there's meanwhile a lot of studies that show that the results are similar to those with an extensor lateral approach, maybe even better, less complications, less scarring, and also less indications for later hardware removal, if you really achieve a good reduction. And this is also shown in meta-analysis. So to conclude with, use your approaches, choose them wisely according to the individual fracture pattern along that lateral utility line that goes from the tip of the fibula to the fourth metatarsal base. And then you will have almost no wound complications. Accurate direct control of the joint reduction, and if in doubt, just stick a dry scope in that really takes you a few minutes and leaves you sleeping quietly. If you have a 3D available in our clinic, it's mostly the spine surgeons and the pelvic surgeons who got it. But if in doubt, this can also be of help. You have less complications, earlier rehab, and at least a better early function after surgery with minimally invasive approaches, but don't trade a small approach for a poor reduction. Thank you very much for listening.
Thank you very much, Stefan. That was an absolutely wonderful talk. So great surgical tips and tricks and very good cases. We'll move on to the last talk of this webinar by Rahul Upadhyay, and his talk is Experiences of the Experienced. So Rahul, if you could please share your screen and start the talk.
Thank you, Arvind. And I think the most experienced person has already spoken about the sinus tarsi approach of the calcaneus. So I'll just try to share in a nutshell. So I hope my screen is visible.
Definitely, go ahead.
Yes. So now we'll be talking about how the sinus tarsi approach has taken over the management of calcaneus fracture over the years. And definitely there are certain advantages it has over the extensile lateral approach that has also prompted me to use this approach exclusively for last 7 to 8 years, where I've absolutely stopped using the extensile lateral approach. Having said that, extensile is definitely one of the best approaches, but whatever approach we are going to use, be it extensile, percutaneous, or the sinus tarsi approach, the message which has been said and given loud and clear before also is an absolute anatomical reconstructions. So for the name of a percutaneous reconstruction or fixation, we cannot have something like this, because this is something as good as having no reduction. So there is no discussion now whether the operative calcaneus are better or not. But before going to the sinus tarsi approach, one very important message that I want to give is that I use this particular paper to guide me. Now, this particular paper has been given for a malunited calcaneus, but what they talk about is what are the main factors that trouble a patient after the calcaneus is malunited. So it's arthritis, exostosis, the neurological outcomes, the deformity, implants, and the soft tissues. So when you're going to approach your calcaneus by whichever approach you are going to do, whether it's extensile or sinus tarsi or the percutaneous, if we are going to make sure that the least possible of all these outcomes, of all these pointers we can give to the patients, we can make sure that overall outcome of the patient is going to be good. Why extensile approach I'm just starting to show is because, yes, it gives us a brilliant exposure to the entire bone, to the entire fracture fragment. We can see the lateral wall. We can reduce it directly under the vision. And we can get an absolute anatomical reconstruction. But what if we say, and what if we can now do the exactly same thing with a smaller approach? I have no doubt that all of us are going to use the same approach. So there comes the sinus tarsi approach, which is going to help us in achieving almost everything that an extensile approach gives us. So these are some of the plate designs that we can use depending on what kind of fracture fixation we are doing, what is the particular fragment, whether it is tongue type, whether it is posterior tuberosity, only just the anterior tuberosity. And we can choose our own implants. I'm a big fan of the plates rather than just the screws, because I would love to mobilize my patients on day one without any cast or slap to them. So sinus tarsi approach is thereby helps me to get those patients quick and fast back to their outcomes. So if you see, again, one of those fractures where we can see different parts of this posterior facet lying with engaged medial varus position of the posterior tuberosity. And I think the professor has already explained very well how to approach this and get this varus tuberosity back into the valgus position, either by a distraction or by the tools like a Hohmann retractor, or maybe by the McDonald's or the osteotome. But what we need to see is, once these type of fractures they depress in a 3D reconstruction, it says that you can have a look at these 3D reconstruction, and you know that a facet has already gone inside a well. So it has caused and created a well, and you are supposed to take this out of this well. So we'll just have a small demonstration of how to do. So this is a small incision which has already been explained. And once we have done that, this gives us a direct approach to the posterior facet of the calcaneus and the talus, a direct approach to the subtalar joint. Now we know that once we open it, we can clearly see. We can clearly see where the posterior facet of the talus is, and we can easily figure out where exactly the posterior facet of the calcaneus has sunk inside. So our next approach is going to go inside and lift that posterior process out of it. So you have already seen two different ways to approach it. We have seen how to indirectly get that reduction back into this. I somewhere like to do a direct reduction under the Shyam guidance. So this is my incision. Now I have taken this particular view so that I can show how oblique we have to go. So this is a curved osteotome that I like to use, and this is how oblique our facet is. So this is where I'm going inside and under the lateral surface So once I open up my lateral surface, I go inside the facet, I rest my osteotome under the surface of the posterior facet. So this is where my osteotome is resting. Now, once I have reached here, so this is how it would look inside the CM. If you want to have a look at the CM, this is where your curved osteotome is resting. So if you see, there's a posterior facet which is lying just above it. And now we are going to elevate this slowly. So definitely when it's much more easier than a indirect reduction, because when whatever the fragment is struck into, it is going to come out easily. So we try to push it further up, and now you can see the movement of the posterior facet of the calcaneus slowly going up. So my idea is to realign it back to its original position, keep it there, and do a transfix KOIS so that I can temporarily keep the reduction in the place. So take your time, slowly you have to just make sure that the reduction is perfect. And once you have achieved that reduction, you can do a temporary fixation with a KOIS. So now once I have done the temporary fixation with a KOIS, on the other view, you can see there is some amount of lateral wall blowout because that is from where I inserted my curved osteotome. So once we have done is good or not by doing the Proren's view, axial view, and the lateral view. So this is going to be my final outcome. Now this plate is going to give me a lot more assurance that the chances of delayed collapse, and particularly for me, are much less. I can mobilize these patients very fast. I can start the ROM absolutely on day one. But we can always do a screw fixation. The technique has already been described by Moez, so I would not go into details of the screw fixation. One important or a different kind of fracture pattern is this, which is more of a fracture dislocation rather than just being a fracture, because you would see that the small amount of lateral wall just goes and pinches inside between the fibula and the talus, and it makes this kind of fractures very unstable, and it is very difficult to reduce it, or even if you reduce it, it is difficult to keep it back. So this is where I like to use this external fixator or the distraction device to hold it back at the right position, and then do a percutaneous fixation or the screw fixation for my calcaneus. The young female, where again we have used a sinus tarsi approach, and here you can directly visualize your posterior facet once it has been elevated, and it lies in sync with the posterior facet of the talus. So you know that there are direct visualizations there. You have corrected varus, your peroneal is safe, and you have followed all the pathways to the sural nerve so that you don't injure your sural nerves. And as usual, you have to look for your alignment in all the views. The angles are corrected, the heel varus is corrected. But one important also thing to just say is that sinus tarsi can be used once you have used it again and again and have experienced yourself much in almost all kind of fracture patterns. Something like this. So if you see, there is not just a calcaneus fracture, there is also something avulsed showing which that there is an avulsion over the fibula, maybe an ATFL. There is something wrong with the medial malleolus also, and there is a complete combination of the inferior wall. So again, a sinus tarsi approach is a beautiful approach, and you can use even in these kind of severely comminuted fractures and displaced fractures. Also, the added advantage of this is this small approach can be used in severe cases of fracture dislocations also. So this is a severe case of calcaneus fracture dislocations with the talus body. The calcaneus is absolutely moving out of it. And if you see, there is a collapse of the medial or the fragment. And what we have done is we have reduced it and used only the KOIs to hold the entire foot back in the position. This is 3 months post-op after that. Some other examples just to show that the sinus tarsi approach or the plate is a beautiful way to reduce your fracture fragments, reduce your reduction and early mobilization. The offset is clear, the fibular calcaneus lateral wall offset, the bolus angles have been maintained, and the heel varus has been corrected. So all these parameters are very vital, and you make sure that you have corrected once before you close your patients. One more important indication for a sinus tarsi approach is a bilateral calcaneus. It saves up your time. You can address these patients fast, fix up, and mobilize them as soon as possible. So, sir, some other examples that we'll not go into detail of a sinus tarsi fixation by the plates, and as I said, I like the plates. But the most important is check all the views before you cover the patients. And one more thing before we end is in cases like these, the severely comminuted type 4 fractures, and when you have associated open injuries, for example, this boy, this little boy, 18 years old boy, had this kind of fracture with a plantar open wound were present, and type 4 calcaneus fracture. So we have to assess these patients as to what best outcome we can give to these with least possible complications and reduce the stage of surgery if we can. So our aim is to have the maximum with the minimum. And again, as we said, the theme of today is the less is more. So sinus tarsi comes very handy into this. So we have used those plantar wounds to reduce the inferior surfaces back to its normal position. We got our anatomy of the entire calcaneus back. We used the bone graft and did a primary fusion for this. So what to address is very important: the facetal depression, the subfibular impingement, heel widening, and the talus attitude. If we have addressed all these things, we are very sure to save ourselves from these drastic and dangerous complications. But having said everything, what is most important and has been proved again and again in all the papers and meta-analysis is, whichever approach we are using, we have to have a best anatomical reconstruction of these patients. If we can achieve that, sinus tarsi is absolutely a boon for the calcaneus fractures. Some take-home points would be that it definitely has a lower wound complication rate. Anatomical reconstruction is possible in all fracture types, whether it's type 2, type 3, or type 4. What we have to do is we have to restore the calcaneal height, we have to correct the heel varus, we have to make sure there is no lateral wall blowout, we have maintained the talocalcaneal inclination. And of course, this has a large learning curve, but the benefits of having moved over from extensor lateral approach to the sinus tarsi, once you see them, that you would not definitely regret the learning curve that you have traveled. Thank you.
Thank you very much, Rahul. That was a very, very comprehensive talk. There are a few questions, and I think we might have just a little bit of time to ask Professor Rammelt. Stefan, can you hear me?
Yeah.
Yeah. Now, first question, if I might ask you, is...
I would respectfully disagree that this is an extra-articular fracture, because it goes into the medial facet of the subtalar joint. And even if the sustentaculum is fractured as a whole, the facet is depressed. And if you don't correct it, the heel will go into varus. So if there's a sustentacular fracture, which can happen in isolation, I use exclusively a medial approach. If there is really a comminuted Sanders 4 that extends into the medial facet, I sometimes feel I have to start with the medial side and then go back to the lateral side and build it up from there. But this is very, very rare.
Thank you. Another question that was put by the audience is, how often do you either have to remove or divide the CFL ligament? And if you do have to divide it for exposure, do you go back and repair it?
When I did the extensor approaches, I always divided it, because otherwise you don't come to the lateral wall. And also now, if I slide in a plate, I just cut it and it heals by itself, as it would heal if it's in a case of an acute rupture. I have yet to see a lateral ankle instability after calcaneal fractures. In contrast, most of the patients end up rather a little bit stiff on the lateral side.
That's exactly, I think, what most of us who have been doing sinus tarsi for quite some time would probably, agree with what you have said. Another two quick questions before we wind up. Do you ever feel there is a need for bone grafting these?
Rarely ever. Only in open fractures, if there's some parts of the calcaneus really on the street. Then you have to somehow make up for it. Of course, also with extensor approaches to really move them rapidly, but with a sinus tarsi approach or with a percutaneous reduction, you really can move them from day one, as Rahul also said. This is and for me that's the same if I use screws or plates. That really depends on the size of the fragments and the bone quality. So I really move them from day one so that they can benefit. That's also the reason why I don't like transarticular wires, because there are some publications with percutaneous reduction and then multiple transarticular wires. Number one, these tend to create some cysts or even osteochondral lesions. Number two, patients are stiff in the subtalar joint, so they don't benefit from a small approach.
Well, thank you very much for giving us your time, Stefan. It has been an absolutely fantastic webinar, and we are very thankful for you joining us.
Thank you for having me. I'm very honored.
And before I wind up, I just would like to say how informative, how enlightening, and how interesting all the talks have been. And I you.